Good morning, everyone. My name is Richard Ponte, and I'm the Director of Events and Programs for the Maine State Chamber of Commerce. On behalf of the entire team here, it is my pleasure to welcome you to Strengthening Rural Healthcare in Maine, the latest in our webinar series. Thank you for joining. Before we get going, there are just a few things we'd like to share with you about today's session. All participants are in listen-only mode. Please submit questions using the Q&A function. Time permitting, we will answer them at the end of the session. We will also use the Q&A feature to share useful links and other materials. We have enabled closed captioning in English. You can access this feature by toggling on the taskbar at the bottom of your screen. The meeting is being recorded, and we will make the recording available to you in the next few days. And finally, if you lose connection, please use the same Zoom link to reconnect. We would now like to begin by thanking our sponsors. Our premier sponsor is Cross Insurance. Our 2026 webinar series sponsors are AARP, Central Maine Power Company, KeyBank, NextEra Energy Resources, and Northeast Delta Dental. And now, here is a word from premier sponsor, Cross Insurance.
What is insurance?
Sure. Insurance transfers certain risks between parties.
Without insurance, the economy would really stop.
In simple terms, insurance is like community.
It's protecting every last asset that somebody has built over a lifetime.
You're in it together. You feel supported.
From the beginning to the end.
What insurance is just taking care of people. It's definitely a way of life.
Again, many thanks to Cross Insurance and all of our sponsors this morning. It is now my pleasure to introduce the President and CEO of the Maine State Chamber of Commerce, Patrick Woodcock. Patrick will be moderating the conversation today. Good morning, Patrick.
Well, good morning. Thank you to our sponsors, and thank you all for joining this morning. The Maine State Chamber of Commerce is always focused on elevating the most consequential public policy issues facing our state and facing our business community. For many, the Rural Health Transformation Fund may be a new topic, but a lot of us are experiencing the challenges of a fragile healthcare system. Just before the new year, Maine received almost $200 million in a fund that is fast-paced and goes to the heart of one of the most important economic issues of 2026. How do we retain critical services in healthcare providers, address the fragility of many of our hospitals, while also looking to transform our health and get better outcomes in our healthcare system? We're so pleased today to talk about what those priorities are. Right now, there are many sections of our state that are grappling with concerns of whether we'll have maternal care, child care services, and ultimately whether rural health can be maintained in our rural economy. We're very pleased to have a number of speakers today that will be talking about what the state's priorities will be, what they should be, and ultimately how can Maine make the most out of this one-time federal opportunity. This is going to be a fast-paced public policy initiative, and leading that will be the Department of Health and Human Services. I want to thank Commissioner Gagne-Holmes for joining this morning. We'll talk through the legislative history, the requirements of the program, and priorities of the Mills administration. We'll also then turn to Jeff Austin, who is the incoming president of the Maine Hospital Association, Trevor Putnacki, who's president and CEO of the Healthcare Purchaser Alliance, and Lori Dwyer, president and CEO of Penobscot Community Healthcare. Please do type questions in the chat if you have them. And again, thank you to our sponsors for leading this discussion today. I will now turn to Commissioner Gagne-Holmes for an assessment of Maine's plan for the Rural Healthcare Transformation Fund. Commissioner.
Thank you very much, Patrick. I'm pleased to be here and looking forward to sharing information around the Rural Health Transformation Program. So I thought we'd start with an overview of the Rural Health Transformation Program, the opportunity, how it came about, as well as how we developed our proposal, what's included in our proposal, our award, which you alluded to, as well as next steps. So the Rural Health Transformation Program was created within the Federal Budget Reconciliation Bill, H.R. 1, also known as the One Big Beautiful Bill, that was signed into law on July 4th. H.R. 1 does a number of things. It will cause Maine to lose approximately $5 billion in federal healthcare funding over 10 years. The projected impacts include rural health providers, putting rural health providers at risk due to an increase in uncompensated care as a result of more individuals being uninsured, and higher costs for consumers in general, just with health insurance costs. At the same time, the Rural Health Transformation Program was also included in H.R. 1 as a federal initiative to bolster rural health. Its total is $50 billion over 5 years. It will be distributed by the Centers for Medicaid and Medicare Services. The funding itself was two parts. Ultimately, a state could get up to $200 million a year based on this. And I'm going to go to the next slide. So the federal Rural Health Transformation Program goals, according to the federal government, was to focus on making rural America healthy again, sustaining access in rural America, increasing workforce development or promoting workforce development, innovative care, and technology innovations. The statutory language in H.R. 1 with regard to the Rural Health Transformation Program required states to choose from these 10 elements. Suffice it to say that the state of Maine ended up pretty much touching upon every element on this slide. There's also some restrictions on how the funding can be spent. So we can use the funding to transform care, how we deliver care, to improve access to and quality of and cost of healthcare in rural America, expand and enhance services, but not duplicate programs, and really promote and implement technology and other infrastructure investments and startup costs that will have sustainable impact beyond the end of the 5-year program. What we can't use the funding for, according to the notice of funding opportunity, is for new construction, for clinical services that duplicate billable services, and a few other things that I will not bore you with. The timeline of this opportunity was very brief. So CMS announced or released its application on the 15th of September, and all applications were due by November 5th. In that very compressed time frame, the department decided that it really needed to engage with stakeholders in order to develop a plan that would transform how we deliver healthcare in Maine. So on September 17th, we launched our public engagement process. It included a number of webinars. It included listening sessions across the state, opportunities for anyone to provide comments about what the plan should include. And ultimately, on the 5th, we successfully submitted our application. So first we listened. This now will be how we developed our proposal. So next slide, next couple, I guess. So as I mentioned, this is not something that state government can do alone. It has to do it in collaboration and in partnership with communities across the state, with providers. And we took that very seriously. So there is a Maine Rural Health Transformation Program landing page on our website. That link will come later in the presentation. As I mentioned, we hosted a public comment period, webinars, and rural community listening sessions. And what we heard was pretty consistent across all of these different engagement opportunities. And that was unaddressed root causes of disease and barriers to care, such as transportation, concerns around workforce shortages, identified gaps in technology and infrastructure, concerns about losing access to care once the community engagement workforce requirements go into effect in 2027, and financial instability of hospitals and providers serving rural Mainers. So these themes guided our approach to the Rural Health Transformation Program. So really our application is focused on empowering rural Mainers to achieve their own healthy living goals. So adopt and expand proven population health solutions that promote timely access to high quality preventive, primary, chronic, and specialty care across the lifespan. Expand the supply of care, so grow Maine's rural healthcare workforce. Spread technology and innovation that connects every community to advanced care, and ensure care will be available and affordable long into Maine's future. That was stressed throughout this process, was that although the funding was for 5 years, the initiatives and activities under those initiatives really needed to be sustainable to strengthen healthcare delivery for years to come. So our proposal, we envision a future rural health system that bridges the rural divide, that provides seamless delivery. So a stronger rural healthcare workforce, innovations and technologies to ensure convenient, accessible, and effective care, and that care is available to rural Mainers when they need it and where they need it. And other efficient, incentive-aligned systems, such as communities come together to reduce fragmented service delivery, so maybe a regional approach to how care is delivered, value-based payments to move us beyond fee-for-service, ensuring dollars go further, and rural health systems are strong and sustainable for future generations. So in short, we envision a future of rural health that is resilient, integrated, accessible, and delivers consistent, high-value care and better health outcomes statewide. So our initiatives, 5 buckets, align very closely with the purpose of the Rural Health Transformation Program, quite purposefully, and that is focused on population health, workforce, technology innovation, access, and sustainable rural health ecosystems. I'll take time to go through each of these initiatives on the upcoming slides, and we've provided some examples of activities. This is not the full array of activities that fall under each initiative, but they do provide a good overview of what's intended in these initiatives. So population health, it's really empowering rural Mainers to achieve their own healthy living goals, to adopt and expand proven population health solutions that promote timely access to high quality preventive, primary, chronic, and specialty care. So some of those proposed activities are to expand alternative sites of care. An example of that is to promote mobile health, to offer additional school-based health services, to integrate primary care with certified community behavioral health centers, anything that we can do to provide additional access, to deploy evidence-based practices for chronic disease prevention and treatment, such as diabetes prevention or falls prevention, strengthen Maine's rural nutrition education infrastructure. They say food is health, so really focusing on nutrition education, expand community paramedicine programs, expand community health worker and peer support programs, and support access to mental health and SUD support. The second initiative is workforce. And during the Maine Jobs and Recovery Plan, there was significant investments in workforce, and this is really building off of some of those successes. So it's to, again, grow Maine's rural healthcare workforce across the continuum of care. Some of those activities, and many of these activities under this category, under this initiative, were influenced, as I said, by our rural health, the Maine Jobs and Recovery Act. So it was to focus to train, recruit, and retain healthcare clinicians and allied healthcare professionals, strengthen local talent pipelines, develop and deploy a healthcare workforce data dashboard. And this is something we realized during Maine Jobs and Recovery. We really don't have a good sense of where the shortages of different types of clinicians and allied health professionals are. And so a dashboard that would allow us to see where capacity is strong, where there are gaps, so that we could focus our initiatives in those areas where the workforce was, where there were gaps in workforce. Invest in mobile training labs and simulation centers, and pilot new models in rural workforce transportation. And this initiative here is one that we have collaborated on with the Department of Transportation. The third initiative is technology innovation. So it's to spread technology and innovation that connects every community to advanced care. Some of the activities under this initiative is obviously to expand telehealth services, supports, and infrastructure, support data integration and the reliable exchange of healthcare data, expand the use of consumer-facing health technology tools. And by that, we're thinking about such things as remote patient monitoring, for example, for high blood pressure, enhanced electronic medical record systems. We know that for many EMR systems, upgrades or new systems are needed, and they possibly even including healthcare, school-based health centers, and having access to electronic medical records, which is not consistent across those centers. And also the last two bullets, these are sort of our vision of creating a rural AI hub to support rural providers in adopting healthcare-specific AI technologies that can help them become more efficient in how they deliver care. And also establish a Rural Health AI Innovation Institute to promote development of new AI technologies purpose-built for rural populations. These two initiatives will be focused in 2026 anyway on a planning stage and feasibility, and hopefully we'll be able to grow them out and implement in the coming years of the grant. So the fourth initiative is access, something critical, obviously, to the health and well-being of rural Mainers. And this initiative is really to focus on ensuring access to care, that it's available and affordable across the state. Some of the activities contemplated include implementing more efficient and user-friendly main care provider enrollment technology. We know that the easier it is for providers to enroll in Medicaid, the more providers will have delivering services to main care members. To improve coordination and leveraging of existing transportation infrastructure, to assist rural Mainers to meet their health and wellness needs through technology and mobility planning, and to improve consumer-friendly transparency tools on our state-based marketplace, coverme.gov, to improve access to and create competition for more affordable healthcare plan options on the marketplace. The fifth initiative is one of our larger areas, and that's sustainable rural health ecosystems. It's to ensure a sustainable rural health ecosystem by addressing persistent financial instability facing rural healthcare systems. Those activities are improving rural hospital and provider financial stability through tailored financial management, planning, and targeted investments, and also providing incentives to help sustain and stabilize providers as we transition from fee-for-service to value-based purchasing or bundled models. To conduct rural regional health ecosystem planning and implementation, develop and support adoption of multi-payer alternative payment models, strengthen Maine's interfacility non-emergency transport system, and expand access to high acuity non-inpatient hospital care for children with complex behavioral health needs. So as every other state, we were required to submit a budget, a hypothetical budget of $200 million a year for 5 years. On November 29th, as Patrick indicated, we heard from CMS that we were awarded $190 million for year one. That required us to revise our budget to reduce it by about 10 million. We submitted a revised budget on January 9th, and we are currently working with CMS to provide them with additional budget information that they've requested in the hopes of getting them to approve our final budget as soon as possible so that we can roll up our sleeves and in partnership with many of you begin implementing the Rural Health Transformation Program. This next slide is just basically an overview of how we intend to get the money out the door. State procurement policies and procedures will have to be followed. So our ability to get money out the door we can do it in many ways. We can do some subawards and expedited contracts, amendments to existing state contracts, and some RFPs, which we intend to focus some of the newer innovative initiatives on. There's some more information about just how to go about tracking what's available on the DAP's Department of Administrative and Financial Services website, but I won't walk you through it. It's there if you have any interest. So the next steps for the department in implementing the Rural Health Transformation Program is to continue engaging with Maine communities and providers. We will continue to update our webpage, the Rural Health Transformation Program webpage on the DHHS website. We will continue with presentations and discussions and meetings with key stakeholders, and we are planning 2 additional webinars, one for providers and one just more general in the coming weeks. And that information, once solidified, will be on the webpage that we have that you can access, and I'm sharing the link on the next slide. We're also working very hard to staff up. $190 million is a big amount of money for some very great opportunities, but we need some dedicated folks to focus on this work. So we have posted a number of positions and are in the midst of interviewing for director, deputy director, and some key individuals. We're also working, as I mentioned, with CMS to finalize our budget and to be able to draw down against that budget. So as soon as we have a signed contract, we'll be able to move forward. We anticipate that happening by the end of February. And the next page is just if you want more information, I've listed a couple of websites, both CMS's as well as the departments, and also a contact person, Dr. Lisa Letourneau, who has been leading this work for the department. I will note, though, that if you email Lisa today or for the next several days, you will not get a response. She's on vacation for the next week. So, but please do reach out to her if you do have questions, and she will respond to you as soon as she's back. Thank you.
Well, thank you, Commissioner. The breadth, scope of this activity and the speed by which is really unprecedented in healthcare delivery. I did want to ask a couple questions to expand on your presentation. And if there are questions, please do raise your hand or submit them in the chat. To start with, we've talked a lot about, there's been a lot of press coverage about the closures of rural healthcare providers. It seems to be under a lot of pressure. We're going to hear from the Maine Hospital Association momentarily. Are there specific areas, though, that you see as opportunities that have already been implemented in rural Maine that are examples of success? Are there things that are working well right now that need to be augmented?
You know, what comes to mind for me, Patrick, is the certified community behavioral health centers, which is they're not a fee for service type of provider. They are a bundled payment so that we have I'm going to get the number wrong, but we have probably over a dozen sites across the state right now. It's in a pilot phase with 5 to 7 providers offering these services in multiple locations, which allows the providers to select certain services that they're going to deliver. And so they're not limited to a particular service at a particular rate. Rather, they get a bundled rate for ensuring that multiple services are delivered. And so we want to build on that. We want more of those centers across the state, and we want to integrate primary care to those. So individuals who are perhaps accessing for behavioral health services can also have an array of primary healthcare services delivered at these centers. So that's an example of something that we think has a lot of potential. We also have another initiative that we were awarded in 2025, and that is the Transforming Maternal Health. Clearly, access to maternal health services has been of great concern given the closures that we've seen. And that work is really aligned with the Rural Health Transformation Program in that we are looking at what can we do? How can we change the delivery of services, but do it in a regional way so that individuals don't have to travel as far as they currently need to do for these services. So I think those are 2 examples of some of the work that we can continue to build out.
My last question is any advice for employers? We certainly sometimes look at healthcare as a cost, but it's also as productivity for our workforce. Do you see any collaboration for key employers in rural areas that they may be able to partner in better outcomes with this program?
I do. I really do. And I think it will be new and innovative ways to think about delivering healthcare. But I think under population health, that initiative, I think there's opportunities for businesses who are interested to think about, do they have space, secure room within their office space where they could offer telehealth services for their employees, so their employees wouldn't have to travel distances to access that telehealth service, and maybe think about partnering with a provider to offer on-site some evidence-based practices around prevention, such as diabetes prevention, those sorts of things. I think there's opportunity here for that to really take off under the Rural Health Transformation Program, and that there is funding available to help support businesses who are interested in maybe pursuing that. And we are certainly interested in having those conversations, knowing that access is so critical and that having to travel takes away from productivity. And if we can deliver healthcare services across the spectrum within the workplace, that could be a win-win across the board.
Well, thank you, Commissioner. If there aren't any questions, we will turn to our last panelists. If there are any questions, please do raise your hands. If not, I do want to thank you for joining this morning. This is an amazingly challenging effort on behalf of the state of Maine. We appreciate your leadership in moving Maine to implement this quickly. Hopefully, acquiring additional funds, as you noted, this is just the first phase, and we do think that this is as timely as it comes for healthcare in rural Maine. So we are deeply appreciative of stepping up when Maine most needs it. With that, I did want to turn to the Maine Hospital Association. Jeff Austin has been a long-time member of the leadership team there. I really got interested in this issue after hearing a presentation from the Maine Hospital Association on the challenges of the financial delivery for rural healthcare in Maine. I did want to turn now to Jeff, who is the incoming president of the Maine Hospital Association, of what he assesses of the current landscape and priorities with the fund. Jeff.
Thank you, Patrick. One quick note. I want to say at the outset, congratulations and thank you to the department and that whole team. What they did in a very short amount of time in turning around a really big lift applying to the feds and getting awarded essentially virtually every dollar they asked for. It was pretty remarkable what that lift that they did. And 190 million or so dollars for the next 5 years. It's pretty incredible. Even the federal people who were running it didn't have time to set it up for the states to participate in it. And so they deserve a big congratulations for what they were able to accomplish just putting us in this position. I was in a call with colleagues. I think Massachusetts, which is much larger than us, got 40 million less than we did. So it's a really good thing what they did, and we're very hopeful and appreciative of their efforts. The application that the state submitted is over 100 pages. I don't expect the people listening to the webinar to read it, but if you do nothing else, read pages 2 through 8 at the very beginning. It is an incredibly sobering overview of rural Maine. It is very well done, from demographics to health to financials. It really tells you the challenges we're up against in rural Maine, and I would recommend its narrative. It's not sort of the bureaucratic part of the application. It's narrative form and easy to read, but quite sobering about the challenges that rural Maine faces. Just one statistic, the way the feds told us to define rural, we have about 23 hospitals in rural Maine. 8 of them, a third, failed all 4 financial health metrics that Standard & Poor's has for hospitals. So our members in rural Maine, like much of business and industry in rural Maine, it's hard to make a go of it. And so we are really hopeful and needing some transformation, because just as it's hard for hospitals to make a go of it, it's hard for patients and businesses and government to continue to do everything the way we've been doing them. So for us, hospitals and other providers are going to plug in to the fund in sort of 2 ways. Some is sort of easy to understand and direct. So for example, our members have a lot of technology needs. It's hard to keep up with that. And so some opportunity to get direct subsidy for infrastructure investment like electronic medical records, telehealth, stuff like that. It's kind of easy to understand. We also benefit greatly, we're hopeful, from some indirect benefits. That is, the rest of the healthcare ecosystem, our partners at federally qualified health centers, ambulances, nursing homes. We need every other part of the healthcare system to function as well. So to the extent the state can make investments in some of our partners, that does help hospitals. An example is we get a lot, and this makes it in the newspapers, we get a lot of kids with behavioral health issues who get sort of stuck in the hospital. The parents bring them into us in the middle of the night because they have nowhere else to go. And they really don't need the medical care that a hospital provides as much as they need community care. So we'll make this plan calls to try to build out that system and make some investments in that system so these kids don't get stuck in the hospital. Obviously, the primary benefit is to that child and that family, but it helps the rest of us who are trying to do our other jobs. Probably the biggest issue for us that's in here is what the state is calling the healthcare ecosystem in rural Maine. There are a lot of the stuff that the commissioner is talking about is being done, right? We're thinking about these things, but we often do them ourselves. This hospital is figuring out how to survive. This health center is figuring out how to survive. Nobody's responsible to get everybody together and look at the ecosystem in its entirety. That's not anybody's job. And it's hard to find the time and money to do that. And this fund can help us look at the ecosystem. I think everybody thinks immediately of less, doing less and fewer. But I think we will see when we look at some of the rural ecosystem that more is needed. We have lost nursing home beds. Someone needs to look at a region and say, this region needs more. We have lost crisis beds for children. We need to look at the regions and say, this area needs more. So definitely there's a big emphasis on efficiency and making sure that we can get access to rural Mainers who need it. And some of it will be redesigning systems, telehealthing in transportation and the like. But other planning parts of the planning process might identify big gaps where we need more. So that's the big unknown, is how the planning at the regional level will look, and what we see when we take that broader lens than any of us can really have when we're doing our day jobs running a hospital or a health center.
Jeff, for those who don't follow healthcare closely, could you expand on just what are these financial pressures? What's really driving this financial fragility for a lot of rural health hospitals right now?
Yeah, I think it starts with demographics like any other industry. When you lose population, you lose employers, and you had a system built with more people and more commercial insurance, which is the better paying insurance compared to government insurance, Medicare and Medicaid. So as the demographics in rural Maine shift away from big employers at a mill with Anthem and Cigna that pay really well for services, and you shift more towards retirees on Medicare and bigger pockets of poverty, which rural Maine has on Medicaid, your financial underpinnings change. You get a sort of double whammy in rural healthcare where there's a very linear graph that as you age after birth, but after age one, healthcare costs go up as you age. So as rural Maine ages, it needs more services and consumes more services, but the payers are aging out of commercial insurance, Anthem and Cigna and the like, which pay better, and into government programs like Medicare that pay less. So we're delivering more services for lower reimbursement. It is expensive to operate. I think people often think of the divide being expensive parts of the state versus inexpensive. That may be true in some ways, but to attract a workforce, I think many of your employers on this call will know, to attract workers to rural Maine costs money. So the basic of demographics is probably the leading issue for us, as it is for many industries in rural Maine.
Jeff, you want to talk about technology? There was the reference to artificial intelligence, the efforts on digitizing documents. Do you see opportunity there for technology to reduce costs, transform services?
Yeah, absolutely. And that's not new. Obviously, technology can provide us a lot. I think for rural transformation, a lot of what we're talking about is making sure we're thoughtful and intentional in deciding what are those things that have to be delivered in person locally. A lot of primary care services and things like that. What can be delivered regionally, as the commissioner mentioned, with physical connectivity, transportation, and the like. And then what needs to be delivered more globally through telehealth, and sharing of medical records. So what has to be done well locally? It's really a lot of primary care and things like that. What gets delivered regionally, and do we have the transportation systems in place to allow it? But electronically, everybody, the big hurdle of getting consumers comfortable with doing healthcare over telehealth, the dam broke with COVID and Zoom and what we're doing today. The consumer, I think, is now much more ready for this as a method of healthcare than they were 10 years ago. And we just need to be sure that everyone in rural Maine has access to that, because it's available. It's here. And so we need to do this planning and make sure that, as you said, whether it's at your employer's office, at your school, at your community health center, or at your hospital, that you are given access through technology to everything that's available through technology. And this will be very helpful in that regard.
Well, thank you, Jeff. We sometimes take for granted healthcare services as the employer community, and we're starting to see what that has been for foundational for economic activity. It's very hard to see economic growth when maternity wards, maternity services, and attracting workforce. So we we need to partner together to make this a success. I did now want to turn to Trevor. For those who are unaware, and it would be helpful, Trevor, for a quick background. Um, the Healthcare Purchaser Alliance represents a lot of the employers that are paying the bulk of insurance costs in our state and has been a really important voice in healthcare discussions in public policy in Augusta and beyond. I'll turn to you, Trevor.
Great. Thank you, Patrick. I appreciate the opportunity to be involved here. I think you were spot on in saying that the lack of access to services in communities has been a real economic challenge for businesses who, it's hard to go set up or expand a business if you don't have access to critical services in your community. I think the flip side of that is that the overall amount of money that we are spending on healthcare in the state has also become a real impediment to economic growth. I think the last figure I saw was about 10% of household income is now going to healthcare services. And that's due in large part to a lot of the stuff that Jeff talked about, right? Our infrastructure is just no longer set up really to be efficient. It's very fragmented. The demographics do create real financial challenges for hospitals. The way that we pay for healthcare, I think presents a lot of misaligned incentives within the healthcare system. So I do see this program as a huge opportunity for Maine to sort of get on the right pathway. I mean, I think it's probably not realistic to expect that, in the next couple of years, we're going to solve all these huge problems that have taken decades to materialize within the healthcare sort of infrastructure in Maine. But there are some real bright spots, I think, that we can learn from and help move us down the right direction. I mean, I think what Lori has done at PCHC and the breadth of services that they're able to provide across their practices really can serve as a great model for what rural healthcare could look like going forward. PCHC has added infusion services that are a fraction of the cost of getting those services within the hospitals. They have in-house pharmacies, behavioral health integrated across their practices. I'm sure Lori could talk more about that stuff, but it just doesn't really make sense to have, community hospitals delivering the breadth of services that I think that they have traditionally delivered, because the cost structure just doesn't really make sense for that anymore. And I think from our members' perspective, and I think broadly the purchaser perspective, we can't continue to sort of put Band-Aids on the systemic issues by throwing more money at them. Healthcare has just, healthcare affordability. There was just a survey from Kaiser Family Foundation that found that people in America are more worried about healthcare affordability than they're worried about housing affordability or grocery affordability. There was a great survey last year from Consumers for Affordable Healthcare that found that 1 in 3 people are skipping or delaying care because they can't afford it. We now have almost 70% of our population in high deductible plans and one of the highest individual deductibles in the country. And that's really sort of how businesses, I think, have tried to manage rising healthcare costs, is by shifting those costs. But we're finding that we can't continue to do that because it's having really, really negative impacts on the community. We need to get a handle on the underlying cost structure. And I think the buckets of work under this grant are exactly where we need to be focused. How do we better coordinate care within our communities? How do we leverage technology to deliver care more efficiently and effectively? How do we get ahead of, these, chronic conditions and things that we know drive a lot of costs downstream so that we can keep people healthier and out of the hospital long term? So I don't want to take up too much time. I'm really curious to hear from Lori, but if you have any questions, I'm happy to weigh in.
Well, thank you, Trevor. You reminded me of a comment from one of the hospital executives that post World War II, when our healthcare infrastructure was really created, it was designed for trauma, kind of coming out of World War II and addressing orthopedic, cardiovascular. And now when you look at services, it is behavioral health, thinking about preventative care, primary care support, mental care, And we're really not, that infrastructure is not designed. I wonder, there is a limitation on buildings, infrastructure, but how to move in a way that actually gets into bending the cost curve rather than supporting the existing infrastructure. And I think it goes to Jeff's comment before of hospitals sort of working together to address this and not as a singular provider.
And I think having that leadership from the state is going to be so important. Before my time really in this industry, there was a Durago group led by the state that brought, providers together to talk about where we need services in different parts of the state. And this has started to come up in conversations again. And I think it would be great to see something like that arise out of this grant. We don't need the duplication of services. We don't necessarily need to providers in a single market offering a really high cost, imaging service or infusion services. Let's figure out what we need to get meet the needs of the community and who can do that most cost effectively, and let them sort of focus on that service.
I'll just ask lastly, can you give a sense of what you're hearing from your membership? It's been a very challenging last couple of years on healthcare costs, but there is a point where it is a bit of a breaking proposition for employers offering healthcare services. I've spoken with some employers that are, some great employers in our state that are having those questions of like, can we really offer this healthcare benefit at these costs?
Yeah, I think that's exactly right. That's what I hear from employers above anything else, is they can't continue to absorb the cost. I mean, the average small group market premium increase in this year was 23%. I think 23 and a half. Or no, I'm sorry, 18%. The individual market was 23%. I met with a relatively small social services nonprofit who was telling me in the last 4 years their healthcare premiums have doubled, gone up 100%. I mean, and it's not new. We've been outpacing healthcare costs have been outpacing inflations by a factor of 2 or 3 for years and years, and really significantly outstripping wages. And this is where we started. My comments. I think it is a huge suppressant on economic growth and activity in this state when more and more dollars that you would be putting into building your workforce or investing in your business have to go to covering rising insurance premiums. And some of that stuff is really just structural, and some is very difficult to address. But I think the timing on this grant is great because we need this now more than ever. Yeah.
Well, thank you, Trevor. I did want to turn to our last panelist here. Lori Dwyer is president and CEO of the Penobscot Community Healthcare. Trevor referenced the work that they're doing already, but Lori, I'd love to turn from you. You're a provider in a rural area, what your priorities are and what you're seeing for stress on the system today.
Yeah, thank you. It's first of all, I want to thank you for pulling this together. This is a great discussion. Thank you, Commissioner, for being here and presenting the information as well. It's hard to add to what has been said, but what I will say, I want to underscore a couple of points and then speak to sort of PCHC's model and the FQHC model. So I want to underscore a lot of references have been made to the ecosystem, right? And how do we make sure that we have the right services in the right places? They're not duplicative and they're the most cost effective. What we have right now, honestly, is a disease care system, which you referenced, Patrick. We're trying to retrofit to a preventative care system, right? We keep trying to sort of throw different initiatives together to build on our what we know is the right thing to do, which is to get upstream and prevent chronic disease, keep people healthier, et cetera. But we have all sorts of barriers really deeply baked into the system. There's perverse incentives. It's impossible to survive as this type of provider if you don't do X, Y, and Z, which isn't necessarily focused on prevention, right? So my hope for these funds is that we look at the existing system and we really start to think about that shift in a deep and meaningful way, because it's going to require a lot of very difficult work and lots of collaboration across all of the healthcare entities. And we tend to think about, when we think about healthcare, just everybody typically, when they think about healthcare, tends to think about hospitals and hospital systems, which we desperately need. But there's a whole other ecosystem that Jeff talked about: nursing homes, ambulances, emergency services, primary care, independent primary care, FQHCs, rural health centers, mental health providers. And we're all existing in a very fragmented space. So I think these funds give us a real opportunity to start to really get underneath that and get rid of the fragmentation to the maximum extent possible. So to be able to get time, space, and facilitation to pull those parties together and have these difficult conversations, I think is a really important part of this. I also want to thank you, Trevor, for talking about the work of FQHCs. I know, Commissioner, you mentioned the CCBHC model, but the FQHCs have been around for a very long time doing quite similar things, although I'm very supportive of CCBHCs as well. But we have an integrated care model with behavioral health services, as Trevor mentioned, dental health care. We tend to forget oral health care is part of healthcare. So we've got oral health care services, mental health services, social work services, and pharmacists, as well as primary care pharmacists and pharmacies. So we have a lot of all the pieces outpatient that can help to get upstream. There's a lot of that work that we don't get reimbursed for, right? And we're sort of trying to figure out, how do you sustain primary care pharmacy? There's no individual reimbursement for that. How do you sustain primary care registered nurses? There's no specific reimbursement in FQHCs for that. So those are things I think that can be worked on and tackled from a sustainability standpoint. The other thing I would say is, I just want to give two examples of what already exists. Like, there's 20 FQHCs across the state. We are the safety net providers. We serve 200,000 patients, and each FQHC is doing sort of community-based projects that their community needs. One thing we did in Jackman, we have a rural clinic in Jackman. They had emergency care services there for years. The community said that is very important to us. We're an hour from emergency departments in either direction. We need emergency care. There was no way to recruit a new provider who was going to be primary care and emergency care and everything else. So we built a partnership with Northeast Paramedicine. We built apartments. They come up, they stay for 48 hours in those apartments. They provide 24/7 emergency care, and then they also provide support for primary care in the clinics during the day. So they have an expanded scope of practice to help in the clinic. They also do community paramedicine in Jackman. So it's a very efficient way to get a lot of healthcare needs taken care of, but there's no reimbursement for anything outside of traditional paramedicine services right now. So it's hard to sustain. Second example is home care. Somebody already mentioned home care. We did a home care pilot project. It's very inefficient, right? If you're in a fee-for-service model and you have to drive from house to house, it's not a sustainable way to take care of people, but we know it lowers costs, and we know it's the best way to take care of a lot of people. So those are two, I think, small examples of ways that we already have people doing this stuff. We need to identify who's doing what, right? Pull everybody together, I think, and then figure out, how do we leverage the existing work, expand upon it, and then make it sustainable in the longer term? What's the structural changes that have to occur?
Lori, just to clarify, federally qualified health center, that's PCHC. And how do you, when you look at this fund, how do you see yourself directly collaborating with the state in deploying these funds?
Well, like others have mentioned, we certainly need support for build out of technological infrastructure. So, EMR conversions and different technology platforms that can support healthcare delivery in more rural places in a more efficient way. So that's one very concrete example. I think other concrete examples include the way that we do support for mobile healthcare. So there are use cases where mobile healthcare is very effective and very efficient in keeping people healthy in their community and out of, avoidable hospitalizations. So mobile units, technology infrastructure, and then nutritionists, right? One of our goals is to improve nutrition, but there isn't good reimbursement for those professionals. So I think working with the department to figure out a sustainable model of employing dietitians and incorporating those into existing healthcare models is also really important. I mean, we have 50,000 patients at PCHC and we employ one dietitian. So, and we could probably employ 20.
I did actually want to turn to nutrition. It's sort of interesting to see that as part of the federally approved goals of the program, and I saw it as part of the commissioner's pillars. Maybe this is a question for the commissioner, but the state has made a lot of progress on school lunches and diet. Is the idea that this funding would be specific to K through 12, or would there be additional programs? Obviously, a massive issue when you start thinking of just nutrition for the general population.
It is more than just nutrition for K through 12. It is nutrition for the whole population. That is one way with population health we think we can make some great strides, is helping people identify how a diet can impact their chronic condition or prevent chronic conditions. So it is very much to be built out in partnership with the provider community, but we do see it as being something that will touch population health.
I do want to just make sure we answer the question. I believe Lori got to that, but there was a question about direct care and whether there would be support for increasing direct care workforce. Lori, you kind of responded that that can be very inefficient and costly, if I'm understanding the answer. Anybody else want to respond to Jessica?
Direct care workforce, I think, is going to be in combination with the delivery of other efforts that are underway or included within the Rural Health Transformation Program. I think what I heard Lori say was the current reimbursement model is ineffective. We do know that treating people where they're at is very helpful. And I think it's, this is an opportunity for innovation. So I don't think, although I didn't specifically address direct care workers, I'm sure that there is an opportunity in some of the population health efforts that we're going to be developing where this will come into play. We have initiatives that are yet to be fully built out given the time frame that we had to submit the application. And we look forward to getting, proposals on how it is we're going to deliver some of these initiatives.
All right, Jessica, I think that's a better articulation of the current model is fiscally challenged, and thinking about reimbursement rates is a big component of this as well. If there aren't any other questions, I do want to thank all the panelists, and also, Commissioner, we will distribute when it is solidified for the additional webinars. We really do think it's going to be imperative that every stakeholder, employer in rural Maine, but across the state, understand this program. And we really do look forward to collaborating with the department and all of the stakeholders in making the most out of this historic opportunity for the state of Maine at a really acute moment for healthcare delivery. So thank you again to our sponsors. Thank you to our panelists. And we look forward to our next webinar next month, where we'll be exploring some of the economic opportunities in research and development in our state. Thank you all, and thank you again for joining us. Take care.